A very good morning, and I will be talking about phacoemulsification in a soft cataract. So what happens really in a soft cataract is the capsular excess can be challenging as these are young patients, they have elastic capsules. Secondly, while phacoemulsification, we find it difficult to hold on to the nucleus because of the density, and therefore we find it difficult to chop, which can lead to formation of a bowl and lead to a posterior capsular blowout. Now, it helps if we use forceps for capsular excess, gives us better control. Even using trypan blue dye makes the capsule slightly more fragile. It makes it easier to tear it rather than without staining. So these are the two things that might help with the rhexis. When we talk about phacoemulsification, where we have a hard cataract, we tend to operate at higher vacuum settings, and because of the density of the cataract, we get a good hold. Whereas in softer cataracts, we tend to operate at lower vacuum settings, and the cataract tends to cheese wire as soon as we try to hold it. The epinucleus can be quite sticky in these cases, especially it can stick to the nucleus if we have not done a good hydrodelineation, and therefore we might find it difficult to pull the nucleus towards the center to chop, and this leads to tendency towards operating in the peripheral unsafe zone when we are not being able to grab the nucleus in the center, and in turn increases the risk of PCR. So let's look at a few of the cases. There can be different techniques to deal with a soft cataract, and I'll just share a few of my videos. So here, this is a patient who is actually undergoing a refractive lens exchange. There is no significant cataract. I have stained the capsule with trypan blue. I find that it's easier to make a capsular excess when we do that. Then we inject the fluid wave. Doing a good hydrodissection and a delineation really helps. And here we just prolapse one of the poles out, inject some dispersive OVD before we go ahead with our phacoemulsification. So we need a reasonably decent size rhexis for this if we need to prolapse one of the poles up. That is one of the prerequisites for this technique. And here I'm finding it difficult to really access the nucleus sub-incisionally, so we can stop, inject some dispersive OVD again under this pole and lift it up, and then further just emulsify it. So here, since we are using very, very low power settings, lifting up one of the poles in the anterior chamber in a soft cataract can really make our surgery very, very easy. And this is towards the end of the case. So this is the first technique when we have a decent sized rhexis and a very, very soft cataract. Now, so this is a case where rhexis is again, okay, maybe 5 millimeters or so, not too large, but still we are able to prolapse one of the poles out. Here, what I'm doing differently is I have done 2-3 waves of hydrodelineation, and we've really taken that hardcore endonucleus that we can see, we have really delineated that. So this is another technique. When you have a small endonucleus, just with hydrodelineation, lift the entire endonucleus up and then easily emulsify. So this is something again that we can do. So the trick lies in doing a good hydrodissection and a good hydrodelineation so that it makes it easier for us to access the nucleus. And then in recently lower vacuum settings, we can use the epinuclear mode to take care of the rest of the nucleus and the epinucleus. So this is another technique that can come in handy when we have a slightly harder cataract with a small endonucleus. Now, this is a patient who has not a very soft cataract. Maybe when we have a grade 1 to 2 cataract, it's a slightly older patient. Age of the patient also matters. So if you have, say, a 60-year-old patient with soft cataract, it will behave differently as a 40-year-old patient would. So here what I'm doing is that I'm rotating the nucleus all around and just aspirating the anterior epinucleus to really access the nucleus and free it up. And then going ahead with the traditional stop and chop. Stop and chop works really, really well for soft cataracts, because doing a direct chop, we might find it very difficult to actually hold on to the nucleus. So here, after creating a trench, the trench doesn't need to be too broad or too deep in these cases. We just need a decent sized trench, and then we can safely go ahead and chop the remaining pieces. We can do a peripheral chop, and that comes in handy. A horizontal or a peripheral chop comes in handy for these kind of soft cataracts. So this is another technique that we can use, especially in slightly older patients where we have maybe grade 1 to 2 of nuclear sclerosis. We don't have a very large rhexis. We are not able to prolapse the entire pole out. Now, this case demonstrates some of the difficulties that we face with these soft cataracts. So my plan is here again, this is a 65-year-old patient, to make a trench, do a stop and chop. I make a trench, I'm able to crack it, and then I'm just planning to chop it. And what happens, typically happens in soft cataract, is that when I'm trying to hold on to the nucleus, it's just cheese wiring and giving away. So what you need to do to get out of this sticky situation, keep a decently high vacuum settings, lower the power parameters, give very low energy, it's 5% power, and then hold on to one of the poles slightly more anteriorly and periphery, and then slowly and steadily keep giving the vacuum at one of the anterior poles, and then just lift it up. So that is the way to get out of a sticky situation when we are stuck and we end up in this bowl formation, and we get stuck of not knowing what to do. Especially for beginner surgeons, it can become quite challenging, and they tend to try and chop in the periphery, which can lead to a posterior capsular rupture. So again, just hold on to one of the poles that you can grab. Do not decrease the vacuum, just decrease the power setting so that it doesn't cheese wire and splice through. And then the rest of the job becomes easy. So to summarize, all soft cataracts are different. They are not all the same. It depends on the age of the patient as well. An adequate sized rhexis, a good hydrodissection and a hydrodelineation really helps in dealing with these patients. We can use different techniques. Either we can prolapse one of the poles of the nucleus with hydrodissection, or alternatively, we can remove the sticky anterior epinucleus, prolapse the nucleus and emulsify. Can use either direct chop or stop and chop, but I find stop and chop is much more helpful for softer cataracts. When we have formation of a bowl, use low power, moderate amount of vacuum, and just try to grab onto one pole of the nucleus slightly more anterior, not into the substance of the nucleus as we would do for a slightly denser cataract. Thank you.